first and foremost, thank you for AstraZeneca to actually organize this. I think this is outstanding event. Assalamualaikum and a very good afternoon to everyone. Dr. Nurhaiti and I, Dr. Azhar, are delighted to co-chair this educational event organized by AstraZeneca. Today, we have the privilege of hosting two esteemed local respiratory physicians, Prof. Andrea and Dr. Aisha, alongside our distinguished international speaker, Prof. Stephanie Korn from Germany. So, welcome to today's discussion on severe asthma, a condition that affects millions worldwide and presents significant challenges in management and treatment. As your co-chairs for this session, it is our privilege to guide you through the exploration of the complexities surrounding severe asthma and the impact of patients' lives and the latest advances in therapeutic approaches. And severe asthma is actually a complex and challenging condition, and the insights shared today are posed to significantly impact the future of asthma management. We are particularly thrilled to explore the latest updates and strategies that are aimed at improving patients' outcome and quality of life, emphasizing the critical role of personalized medicine in tailoring interventions to meet the diverse needs of patients with severe asthma. And today, together, we aim to foster a deeper understanding for this condition and share insights into the innovative research and collectively enhance efforts to improve outcomes and quality of life for this affected. Dr. Hati?
Okay, on that note, we invite all participants, whether you are physically here or whether you're online, to engage with our distinguished speakers, as it will contribute and enhance the interaction and our learning in severe asthma. Right? Without further ado, I would like to invite our first speaker, Associate Professor Dr. Andrea Ban, who is a senior consultant physician and pulmonologist in Hospital Chancellor Tuanku Muhriz UKM, specializing in asthma and COPD. She is currently the head of respiratory unit in Department of Medicine. She obtained her master's in medicine from University Kebangsaan Malaysia in 2006, and since then became a lecturer, physician, and also researcher in HCTM. She has conducted researches particularly in asthma, COPD, and tuberculosis. She is a member of Malaysian Thoracic Society and Malaysian Association for Bronchology and Interventional Pulmonology. She was previously the chairperson of the National Respiratory Exit Viva Exam Committee and the chairperson for the National Asthma Clinical Practice Guideline for Adults. So she will be delivering the talk, Stay Ahead of the Curve, 2023 GINA Guidelines Updates. Please welcome Prof. Andrea.
Right, thank you for the introduction, Yati. Welcome everyone. I'd like to thank AstraZeneca for giving us this opportunity, as Azhar mentioned, to probably just highlight some of the new changes since the last time we met in 2023. So I've been tasked with 50 slides, 25 minutes, and talking about the 2024 GINA updates. So I will take up the challenge to end before the timekeeper gives me something. Okay. So maybe we just probably talk about things that have not changed since the last time we met. So asthma is still a chronic inflammatory respiratory condition. True? True. It still affects millions of people worldwide. True? True. Okay. And there's still challenges in both diagnosis and management. True. That's the reason why we are here giving up our Saturday afternoon when we could actually be shopping for handbags. So this is 2023 since we last met, and now 2024. Right? So you're probably wondering what the stacks of stones are there for. So probably just to remind ourselves that GINA was first published back in 1995. Back then it was simpler and we all thought we were really smart. Since then there have been many updates and it's always very confusing, kind of thing, oh no, just as we memorized 2023, 2024 comes out, damn, right? So the good thing is that between 2023 and 2024, very subtle changes, right, which we'll bring up in the slides as we go along. I think the major updates were actually in 2006, where it moved from consensus to evidence-based, and then the track 1, track 2, which was actually in 2023, and since then, some minor changes. So good news for all of us, I think. So, okay, 2024 updates, talk about the diagnosis, right? So everyone gets excited when we have a look at it. So I think nothing much has changed, except for the fact that in the diagnostic flowchart, they do recognize that in low to middle income countries, spirometry might not be widely available. So then they actually put spirometry or peak expiratory flow, which gets everyone excited, thinking, oh, we can actually use the PEF. We are not low middle income group countries, right? So I think as much as possible, we will stick to the spirometry. So this flowchart allows for a selection of differential lung function tests depending on local resources. So I think probably we look at ourselves to look at what resources we have, right? So I think probably it's important to remember that the spirometry cannot replace the peak expiratory flow, and we should push for spirometry over the peak expiratory flow. If it's not available, and if you then accept the fact that you are in a low to middle income country, then you may use the PEF. Otherwise, don't. So other changes, many, many words. You probably think, oh no, one of those horrible slides, right? So 2024 to 2023, what are the main changes? Well, actually, at a glance, not much. So when we look at the excessive variability, the positive bronchodilator challenge, and the variability in your PEF BD over 2 weeks, nothing much has changed. However, they actually just word it a little bit differently, meaning they're more thorough in what you should do before you actually subject a patient to positive bronchodilator test. So they do say that you should actually withhold the long-acting bronchodilator 24 to 48 hours, as opposed to in the past, where they actually made it a bit differently. And something about children, which we're not really interested in, so we'll just move on, okay, because we're not peds. Other things would be a positive bronchial challenge test. So they are more detailed in that. So if the FEV1 decreases during a challenge test, they ask you to check the ratio, whether it's actually decreased, and blah, 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 right? But I think the important thing would be that the 12% 200 mils remains the same. So we know that there's some differences adopted by the ERS and by the ATS. So GINA actually says that they need more information before they incorporate this into the guidelines. They also talk about cough variant asthma. So I suppose because the title of the talk is Updates in 2024, so this deserves one slide, right? So cough variant asthma, I think it's important to note that it's actually difficult to distinguish from other causes of chronic cough, and spirometry may be normal, right? So just keep that in mind when you actually want to label someone as cough variant asthma. And there's a lot of overlap. So most patients may actually have sputum eosinophilia, and they may also have an elevated FeNO. But the important thing is that patients should be treated in the same way as for asthma in general, and the cough may return following ICS cessation. So what about assessment of control? So I think the newer thing they say is that it should not be limited to recent 4 weeks. Then you say, oh dear, then what should we do? Unfortunately, the tools do not allow us to assess beyond 4 weeks. Just an important thing to note. So we should assess symptom control. No, not just that. You should look at the risk for exacerbations, the risk for accelerated decline in lung function, and also the medication adverse event must be assessed. So unfortunately, what we have is actually the GINA symptom control, which actually limits ourselves to 4 weeks. But I think it's important to note that you should also look at other risk factors as mentioned earlier, right? So this would be something that you need to think of periodically, particularly when patients experience exacerbations. So you want to measure the FEV1 at the start of treatment, after 3 to 6 months of ICS containing treatment, and you want to record the patient's personal best, and it's actually a periodic ongoing risk assessment. So important to note, and this is what was mentioned in GINA 2024. So what are risk factors for exacerbation? So I think we'll probably look at the Sabina study later on, but important to note that SABA overuse is actually a risk factor for exacerbations. Too little ICS, if you're fat, if you've got a nose problem, if you have regurg, if you actually have a confirmed food allergy, and if you're pregnant. If you have ongoing exposure to smoking, e-cigarettes is also a no-no, allergen exposure if you're sensitized, and air pollution, right? Psychosocial, so we know that lower socioeconomic group is actually, there's some studies to prove that it's actually linked to an increased risk of exacerbation, and lung function. When you look at the lung function, please look at the low FEV1. If it's less than 60% predicted, perhaps these are the patients who will actually cause problems later on. Higher blood eosinophils, which were mentioned in some other studies from meta-analysis of severe asthma, high FeNO as well, and exacerbation history. So all of this you need to look at when you clerk a patient with asthma. Okay, so these are the risk assessment. I think we don't look into it, but you should look at your preterm low birth weight, right? So lack of ICS treatment in patients with history of severe exacerbation. Look at the history of what they were treated as, and this is repetitious tobacco smoke and low initial FEV1. So other things would be medication side effects, right? So we talk about burst of OCS, right? So you know that if you have oral corticosteroids being given for more than 3 weeks, there is already a risk of your HPA axis will be affected by that. So high dose potent ICS, okay, something to think about. So we look at treatment goals and approach, right? So this hasn't changed, and this is actually from the GINA 2024. Again, we are looking at long-term asthma control and long-term asthma risk minimization. And other things would be patients' goals. So sometimes we are very focused on what we want. I think it should be a shared decision, because that would actually increase the compliance to medication, the adherence, which has always been highlighted as an issue. So you consider their goals, and you consider their phenotype as well, and your clinical features, again, the risk factors that we mentioned earlier. And again, I would like to stress that assessing symptom control is not enough. You need to look at the risk factors. So this is actually just a slide from page 50 of GINA. Should you not believe me, in the 2024, you can actually fish this up. The goal for asthma treatment is to achieve the best possible long-term outcomes for the patient while accounting for patient's own goals, which may differ from those below. Okay. So again, I think it's repetitious. So if you do not believe me, you can actually open up the PDF 2024 and look at page 50. Moving on swiftly. So remission. I think there's the other new thing in 2024 was that they expanded the definition of remission, probably highlighting the remission of adult asthma. So off-treatment remission has been observed either spontaneously or after cessation of controlled medication or patients with adult onset asthma within 5 years. So how can you predict persistence in a study on off-treatment remission? Well, moderate to severe AHR or nasal polyps, and they do mention on-treatment remission as well, whether it's clinical remission or complete remission. So clinical remission is actually defined as no asthma, no exacerbation, zero OCS, stable, improving lung function over a defined period, whereas complete remission is normalization of your airway hyperreactivity and or your inflammatory markers. And these are some of the proposed definition of on-treatment remission. So we go on to the medication and treatment strategy. So again, I think it's similar to 2023, where you have your track 1 and track 2. So the track 1 is actually looking at low-dose ICS formoterol as the anti-inflammatory, which remains the preferred regime, whereas track 2 is actually ICS SABA as a reliever, right? So this has been replaced. SABA monotherapy is no longer recommended. So this is actually just a diagrammatic thing, which I think most of us have seen it. You may not be very familiar, but when you look at it, you kind of know what it is, right? So if we have a look at this, this is actually track 1, track 2. So the new difference is actually they've merged step 1, step 2. So step 1, step 2 in track 1 is 1, merged into 1, whereas in track 2 is actually still divided into 2. Step 3 onwards is almost similar. So when you look at step 3, in GINA, when someone talks about step 3, it's actually low-dose maintenance ICS. So whether it's actually ICS formoterol or ICS LABA, right? When you look at step 4, in track 1, it's actually medium dose. In track 2, they talk about medium. They do suggest possibility of using high dose. When you look at step 5, between track 1 and track 2, they're similar. You consider add-on LAMA, refer for phenotype assessment, and you consider high-dose maintenance, and then you look at your biologics, whether it's anti-IgE, anti-IL-5, 5R, anti-IL-4R alpha, and your tezepelumab. So this is actually just a meta-analysis, Cochrane review, looking at the low-dose ICS comparing to two types. So you have low-dose ICS formoterol at the top is actually versus SABA. At the bottom is actually versus SABA and ICS. And what we found, if you have a look at this, these are the studies, you can see that there is actually this is actually time to first severe, this is actually exacerbation requiring ED visits and hospitalization. So when you compare to SABA monotherapy, it's actually 65% reduction. When we compare to regular ICS plus PRN SABA, it's 37% reduction in terms of severe exacerbation, either requiring ED visits or hospitalization. So it appears to be that your PRN low-dose ICS formoterol has a superiority when you compare to SABA monotherapy or when you actually compare to regular ICS and PRN SABA. And this is the drive towards putting it as the preferred track. So again, when we talk about step 3, step 4, where's the evidence for it? Where you actually look at if patients on step 3, you want to do low-dose maintenance ICS formoterol, and it appears to be the preferred track in track 1 compared to low-dose maintenance ICS LABA. So again, this is actually from meta-analysis systematic review published, I think, by Richard Beasley in 2 years back. And they actually compared the studies. So this is a meta-analysis. Look at all the studies and they see whether your MUTs with budesonide formoterol versus maintaining GINA step 3 with ICS, LABA, and SABA. And what they found was that the risk of severe exacerbation reduced as much as 30%. And when you compare to step 4, ICS, LABA with SABA, there was a 29% risk reduction in severe exacerbation. So this is actually just fished out in terms of track 1, track 2, and why it was suggested that track 1 is actually preferred over track 2 in terms of your step 3 and step 4. So this is the other difference in terms of the GINA 2024, almost similar, except they actually expanded on the highlighted one in red, where if they actually look at daily asthma symptoms, waking up at night, as well as the low lung function and recent exacerbation. They also looked at symptoms and they brought in your low lung function as well. And this is the main difference between GINA 2023 as well as GINA 2024. So this is actually just highlighting your track 1 ICS formoterol anti-inflammatory reliever therapy medication and doses. And this was the other thing that was the main difference. In the past, the maximum dose was different, but now they actually suggested that regardless of that, when you look at formoterol, the total number of inhalations now would remain the same at 12 inhalations, which makes it a little bit easier for us to remember and to counsel patients. So the other difference is actually in page 156 when you look at the reduction of ICS. So they do mention that maintenance dose of ICS formoterol should not be stopped in patients with severe asthma, but MUT supports the background treatment reduction strategy in biologics. So I think you look at the Shamal study, for example, you can see that when patients are initiated on biologics, there should be an attempt to actually reduce the ICS dose and the OCS dose. Okay, so this is almost similar. Other changes would be the LTRA, allergen immunotherapy, and suggest that mild asthma is retrospective. So mild doesn't mean that you have reduction in your risk of exacerbation, pulmonary rehab, and prevention of occupational therapy. So probably just like to share with you, just recently published in June 2024, to looking at the national expert consensus of SABA over reliance. These are the 11 statements, right? So this is actually, we'll start off with the Sabina, looking at, so I think from the local study, it's been shown that up to 50% of Malaysian patients are prescribed more than 3 SABA canisters per year, therefore they're at risk of exacerbations and mortality. So what is the impact of SABA overprescription? You can see that patients overprescribed with SABA are far less likely to actually have controlled asthma, and the risk of severe exacerbation doubles in patients who are overprescribed SABA. So this is an SCOP study, which is looking at asthma control in primary care. This was actually published a couple of years back. And what they found was factors to predict poor asthma control includes high SABA. Interestingly, in this study, 97% of patients did not have spirometry. They actually have peak expiratory flow rate. So this is a study done in looking in patients in Sweden, right? So you look at the SABA overuse, you can see that when you actually have overuse, or the higher your SABA canisters, the higher the risk of asthma death. So this is something that we should prevent. And this is actually, this led on to the consensus statement, which was actually published, meaning that SABA over-reliance is highly prevalent, it leads to poor asthma control, and is actually a major healthcare issue. So again, this is very similar. The more number of SABA canisters, the higher your risk of exacerbations and asthma-related hospitalization and outpatient visits. So GINA 2024 recommends that symptom control can be assessed via the frequency of SABA use. So how can we assess the frequency? There's this reliever reliance therapy where you actually, just answer the questions and you'll know whether you're reliant or not. So I don't know, most of us actually will send an email to talk about psychological thing, right? So this is similar to what the government wants. So the government asks us to actually answer the questionnaire, and then you can say whether you are stable, or not, or you need to be referred to a psychiatrist. So this would be me, I suppose, stress at work. Okay. So consensus statement, asthma patients on SABA should receive an assessment of risk of SABA over-reliance, and the number of SABA canisters utilized by asthma patients should be controlled and monitored, where they should not exceed more than 2 canisters per year. So again, this is actually inappropriate use with a higher risk of ED visits. And the other thing would be discharge medications should include regular ICS containing treatment, and a follow-up should be arranged. So this is an ideal situation which we should push towards, right? So this comes why we actually had consensus statement number 6, where we actually say that patients discharged from hospital following an acute exacerbation should at least receive ICS containing treatment. So this is actually just to show you a study in New South Wales, meaning 60% undertreated, 69% obtained the SABA monotherapy over the counter, right? Undertreated. And this is actually associated with uncontrolled asthma, with increased risk of use of OCS, and patients who've actually visited doctors in the last 1 year. So SABA should only be dispensed with prescription was our consensus, right? So this is similar, track 1. And we did say that track 1 should be implemented in the management of asthma patients across all severities when indicated. We talked about inhaler technique, we talked about increased healthcare resources, and also research in terms of asthma-related exacerbation and mortality should be our national healthcare priority. So this is my take-home message. When spirometry is unavailable, then only you consider peak expiratory flow, but it is actually less reliable. The bronchodilator responsiveness criteria still remains the same, more than 12% and 200 mL increase from baseline. So comprehensive assessment of patients should not just be limited to symptoms. The goal is actually best possible long-term outcomes. We're not looking at short-term outcomes. SABA monotherapy should not be used, and this is actually as of GINA 2019. MUT maximum dose, same for beclomethasone formoterol and budesonide formoterol. And optimizing asthma management should include inhaled therapy, non-pharmacological strategies to reduce reliance on OCS and to minimize their side effects, right? So I think I'd probably like to end, just like we like to keep our meals fresh and fiery, let's keep our asthma knowledge up to date. And this is the reason why we are here. Thank you very much.